Start streaming. I wasn't hitting that. Oh, we're live, sir.
Now you are.
We
Okay.
are live, and except I have the wrong. I have to close this. Yes, we are live. All right, so we should be live. Do you see? You see us? Accad and Koka. Because YouTube Studio says that we are live.
Okay.
If you click on live, yeah, we are live, dude. Holy shit! There you are.
I'm
Your
there.
face is
Okay.
Your face
Let's
is
go.
going out to the world right now. All right, so it works.
Okay.
I am going to now. I'm gonna go plug my phone in because it's dying, and then I'm gonna put a jacket on, and I have to send this Zoom link to Vince. And then
Yeah, and
what
then
time are we starting?
Al,
We're starting at 4, right?
4. Yep.
Okay, okay. Oh, good.
And
So we
then
can.
Al also texted you his email
Oh, he did.
to send the link.
Okay, good. Yep, perfect. So I'll send him the Zoom link. All right. So actually, we're gonna disconnect right now.
Okay.
And we'll reconvene. I'm gonna send the link in about 5 minutes. Get a jacket. I'll get the Twitter heart spaces thing going. So for that, we'll need the Twitter thing active. Here, let me. Set.
It'll be a different link.
Yeah, it's gonna be a different link. It'll be a
Okay.
different
Okay.
link. Yeah, yeah. Look for
Okay.
that other email.
All right. Sounds good.
Angel Antonio. Dr. D. Angel Antonio. D. Angel Antonio. .com. Hey
Hey
guys,
guys, can you hear
can you
me?
hear me? Yep, I gotcha.
Okay,
Yeah.
awesome. How you doing, Anish?
Good, good. How are you? So now, if you go to Twitter,
Mm-hmm.
um, my most my the tweet that's pinned to my profile is cardiologists discuss outpatient vascular care. I'm gonna start it right now.
What's your handle, Anish?
It's at Anish_Koka.
Okay.
So then we will also be on Twitter Spaces.
Okay.
Oh, looks like I never stopped streaming. And I'm asking my the kids to do a sound check. Can you see us now? Okay. So great. Request.
So I'm on the Twitter space, but
Yep.
I don't.
Yeah, I see
Yep.
you. Yeah, you're there, right?
Can you hear me on both? Is it the same?
Um,
I guess I have to be just as audible on the Twitter, right?
yeah, you just have to have the phone somewhere close to you. The mics are
That's
so
fine.
good now that it's
Yeah.
good. So, um, all right. Well,
So,
great. We
so
just
yeah. Do I just go? I mean, I'm on your site.
So if you
I
go
see.
to
Listen.
if you go to Twitter and
Yeah.
you click on, you see where it says set a reminder for my upcoming space.
Yep.
If you click on that and say join, you see there should be a join button or something on that on Twitter. You have to be logged in as it has to be on your phone. Yeah.
Okay, I'm on my iPad.
Does it
Does that
work on
work?
your iPad? I don't know if it works on the
It
iPad.
should work on the iPad.
I know it does not work on the desktop, but it may work on. Yeah, the app it
Yeah, but
should work,
there's
I
still a
guess.
mobile app on your
Yeah.
iPad. It
I
should.
see listen live.
Yeah,
Yeah.
that's what you
Yeah.
need to do.
Yeah. Yeah.
That's
Just
what you
click
need to
that.
do.
Okay.
Yep.
Yeah.
And then,
Listen.
oh,
Okay.
we'll get Dr. Al.
Hey everyone, thanks for the invitation. Appreciate it.
Hey, of course.
Just working the video piece.
Yep.
Okay. Yeah.
Hi, Al. Al, are you on Twitter as well?
I am not actually. I do not have a Twitter account. Do I need one for this, or
For the Twitter Spaces piece of it, you do.
Yeah.
okay? You try
Did the
to.
audio come through from your end, Anish, or?
Let's see. Well, hold on. Yeah, the audio is fine. I don't see Vincent on the Twitter Spaces.
Yeah, I'm only listed as a listener right now.
Yeah, I don't
Is
even
there a
see.
separate link for the Twitter Spaces,
I
or
don't even see you there
Okay.
because I see other listeners, but I don't see you as a listener. Why is that? Because then I would send you once I see you as a listener, then I can send you a invite.
Oh, okay. Yeah, I see a couple
You are
people.
logged in, right, Vince?
Yeah,
Oh, so Vincent, you see that's interesting. So you see us. So you're logged in. You
I
see
do.
John and
Yeah,
you
I
see
see you
me.
guys like logged in here.
Huh? Why
Oh,
is
I
that?
see you guys as listeners, me. There were two other people there for a second ago.
Yeah, interesting. Let me see. Maybe it's because I don't follow you. That's strange. What's your handle?
My handle's vvarghese.do at vvarghese.do.
Yeah, maybe that's the issue. Vivarghese Do. I'll follow you. Try coming out and coming back in.
Okay.
So just leave the space and then come back in. And then what should I, Dr. Al, or should I Dr.
oh, Al's fine.
Al's fine?
Yeah.
Okay.
Yeah.
Al, let me know if you are able to do the.
Can I log into the Twitter as a guest? Is there a separate link, or how do I
The
access?
Twitter, you need to have an account.
Okay.
Would you be able to set up an account? I should have asked you
No
before.
worries. Yeah.
Not a
I'll-
huge,
I'll-
not a huge deal if you're not on the spaces. It's just we won't be able to hear you on that specific thing. Well, we are live. My daughter is saying that we are. This is all being pushed out right now to YouTube Live. No one's watching, so don't worry.
we haven't said anything intelligent yet.
Yeah, exactly. Vincent, try
Yeah.
on your iPhone. Oh, there, I see. Oh, okay. Yeah, I see Bao. I don't follow, and he's there. So it must not be a follow thing. It must be something with the iPad.
Yeah,
Maybe
I see
something with the
Val
iPad.
there too. Yeah.
Yeah. So try going on your iPhone, get the Twitter app, and download it there.
Okay.
And Al, if you could do the same thing.
Creating a Twitter account now, and
Hey, folks, we will be starting soon. We're just fixing trying to get some people on there. Two other speakers that we're trying to get on. So if you can bear with us. It seems like this only works on the iPhone. Hey, Sai, I'm gonna. Sai can't speak, but I'm gonna invite him. Sai, we're talking about the New York Times piece. I don't know if did you see the New York Times piece, Sai, about the whole outpatient vascular care and all that stuff? You missed it.
Honestly, I haven't paid attention to the world of
Yeah, that's
cardiology.
that. I know that's smart. That's smart. There's this big splashy thing in the New York Times, which is why we have Dr. George here. Dr. Varghese is trying to log on. We're actually Sai. This is going live on YouTube as well. We have the live YouTube start figured out. The Twitter Heart Spaces, which supposedly was the easier one. We're having more difficulty on. Oh, there's Vince. You see, he's on.
Okay.
See, there he is.
Work
Perfect.
on the phone. All right.
Yeah. So it works on the phone. So you have to do it on the phone. All right. I'm inviting you to speak, Vince.
Okay, got it.
And once you get that, you will hit OK. And then
Okay.
all right, great. So all right. So now we're just waiting for Dr. Al, or for Al, and we shall we shall go.
Okay. So he's on Twitter So Al, if you just look up Anish underscore Koka and get on his site, you'll see a link.
ProPublica. Okay, he says he's on the live Twitter stream. You have to be on the Al. You have to be on the on your iPhone for it, though. Are you able to do that? Are you on your iPhone, Al? You can unmute to talk if you need to.
I'm logged in online. I can't download an iPhone. Please.
Oh, okay, so you're not on the iPhone.
You can unmute to talk if you need to.
I'm downloading it now on my iPhone.
Oh, okay,
but
okay.
I'm logged in on Twitter online. Should I
Yeah,
log
yeah,
off?
yeah. Log off there because
Okay.
you can't be a speaker on there. So.
Got it. You guys can get started. I'm logging into
Yeah.
Twitter.
Okay, so yeah, we'll get started. I have let's start with some introductions here. So first of all, we're here to talk about outpatient vascular care. In the words of ProPublica, the wild west of outpatient vascular care. It's interesting about month to month, about 3 weeks apart. The New York Times and ProPublica did a kind of stories on vascular care in the outpatient setting, and it was not a it was not a flattering piece. They basically are suggesting, not just suggesting, they're basically explicitly saying that doctors that are working in the outpatient vascular space are hurting patients and doing it for the sake of profit. So obviously, that's a very strong charge to be out there. I mean, the New York Times had a big full page on Sunday, picture of a woman in a wheelchair with an amputation, and again explicitly saying that amputation happened, because of bad things that doctors are doing. So we discussed this once last Sunday. Great discussion with Dr. Jay Geary from Penn, who is one of the vascular specialists at Penn. It was a fantastic discussion. Unfortunately, Dr. John George, who's here, Dr. George was on there as well, but he got called away for an emergency. So we brought him back because he's got a lot more to say, and it's a different perspective than Dr. Geary. Jay is a academic at Penn, and John is in private practice. With John, we're lucky to have two other folks. We have Vincent Varghese and Dr. Al D'Angelo Antonio. Can you guys give us I'll let you guys introduce yourselves. So go ahead, John. You can start.
Absolutely. First of all, thanks again, Anish, for even having us over again. It was a pleasure to be on for 10 minutes last week, but sorry I got called in. But this is a really important topic that I think we really need to discuss, and I'm excited to be back again and have the opportunity to be able to do that. Again, my name is John George. I'm an interventional cardiologist by training and also endovascular trained. I am in private practice, but also do most of my procedures in the hospital setting at present at Pennsylvania Hospital, so within the Penn healthcare system. And I have one of my partners on here as well, Dr. Vincent Borghese, and I'll let him introduce himself.
Thanks, John. Thanks, Anish. Thank you again for the invite. Like Dr. George mentioned, Vincent Borghese, interventional cardiologist, also endovascular medicine specialist.
Vince, unmute. Sorry, I know it's hard. Unmute yourself on the Twitter space and then talk, because then we're going live YouTube and
Gotcha. I got it. Okay, you should be able to hear me now.
Yep.
So yeah, Vincent Borghese, interventional cardiologist. Again, private practice as well, but endovascular specialist. Spent a majority of my career in the academic setting, though, teaching fellows and still doing that as well. But like John, similarly working in the hospital primarily and doing complex lower extremity interventions. And again, glad to be here to weigh in.
Al, you are also a speaker. You got on, so go ahead, Al. You can introduce yourself as well. Al, you have to unmute yourself on YouTube. Yeah, unmute yourself on the Zoom.
Is that better?
Yeah.
Okay, terrific.
A lot of
thanks for having me. I appreciate the invitation. I've actually known Dr. George and Dr. Borghese for quite some time. I myself, too, have been in the academic setting, formerly at Penn Medicine for 15 years as their chief of foot and ankle. I do foot and ankle reconstructive surgery, complicated reconstruction, a lot of screening for lower extremity vascular disease, and functioned as fellowship director there, and now chief medical officer in a large multi-specialty practice setting. And so excited to have some dialogue around how the peripheral arterial disease affects the lower extremities and how, a lot of multidisciplinary specialists and different disciplines can help optimize care. So thank you.
Awesome. Okay, so everyone remember, I know it's complicated. Mute yourself on both places. So Vince, yeah. Perfect. Yeah. So just, I know this is hard because we're trying this for the first time. I realize this is difficult because we're trying this for the first time, but remember to mute yourself on both places and unmute yourself on both places when you start speaking. Otherwise, there's all this feedback. All right. So we have Dr. George, Dr. Borghese, who are experts in peripheral vascular care in the care of complex patients who have peripheral vascular disease, and Dr. Dr. D'Angelo Antonio is from Penn and is a podiatrist as well. So welcome all. So we'll get started. John, what was your take on the New York Times piece?
Well, as you know, I think it's gotten a lot of publicity, and having a cover page article titled "They Lost Their Legs, Doctors and Healthcare Giants Profited" is going to gain a lot of traction and attention. And so it's really important to get to the background of it and really understand what the story was about. And so my problem, just generally speaking, with the article itself was that the reality is that there is rampant peripheral vascular disease with patients that have lost limbs and are threatened to lose their limbs. But the story was very biased in just one direction. And so that was my primary problem with the way the story was presented. So just in broad category, peripheral vascular disease, when you discuss it, you have, two different arms, so to speak, within the umbrella of peripheral vascular disease or peripheral arterial disease. You have claudicants, or patients that have symptoms that are limiting their lifestyle. And then you have patients that have limb-threatening ischemia, which is where they have gangrene or wounds or skin breakdown or even rest pain. And now it's more of an emergency or dire need to get that taken care of so that they don't lose their limb. So the two patients that they discussed in this article were patients on the second group in the CLTI or chronic limb threatening ischemia patient subset. And these patients have a very high risk of even getting an amputation to begin with. So if you read the story, this patient presented first with a festering wound, in their own words, and then over a course of about 2 years had multiple procedures done to try to save that limb, and subsequently succumbed to having an amputation. It's very different from you know, having to say that a patient went in without any symptoms or went in as a claudicant and then came out losing a limb after a procedure. That's not what happened. And so I think that needed to be clarified, and I'm afraid that they didn't do a good job doing that. And so that's kind of my initial thoughts. I have a lot more to say, but I want to make sure that everyone gets a chance. So I'll stop there, and happy to dive in deeper as we go along.
Thanks, John. Yeah, I mean, just that New York Times case involves, as you said, somebody coming in with an active wound, and there's a very, very high rate of them losing their limb. The fact that they have interventions done and then lose their limb, it doesn't necessarily mean that the interventions, cause it. You may have, and again, the big context that is missing from the New York Times story is that there's an epidemic of amputations, right? And the big problem, which is why CMS change reimbursement to allow more outpatient vascular care, to allow more access for the community to outpatient vascular specialists like yourself, like Dr. George, etc., is because there were so many patients that were getting amputated and losing limbs without an attempt at salvaging the limb, and that was completely missed by the New York Times. So in their zeal, I think, to go after bad actors, they kind of miss that overall context. Can you, Vince? Well, actually, let me get to Dr. Al. Actually, Dr. Al, you're a podiatrist, certainly, right? And you see a fair amount of disease patients coming to you. I mean, is that something that has been created by cardiologists and peripheral specialists, that there's this massive amount of disease that was being unaddressed? Can you talk about that?
Sure, happy to. I think looking at the patient has to be done at the entire patient level. These patients smoke, they're actively diabetic. The article does not mention anything around how controlled their diabetes were they smoking actively when and if they were revascularized. When we see patients in the front end of the spectrum from the foot and ankle standpoint, a lot of these patients have a component of peripheral arterial disease. The immediate pathway and standard of care is to get them plugged in sooner than later. We have actually created limb salvage centers and all the different types of centers that go along to help patients save their limbs, but they have to actively participate in that saving. And so my relationship with the cardiovascular specialist is incredibly tight. As long as I have blood flow, I can get 95% of things to heal, but the patient's aspect of their care, their active participation, again, is never mentioned in any of this. And so, unfortunately, even in the best hands, we get the patients to Dr. George or Dr. Verghese or so on and so forth. These patients also can suffer from microvascular, which is called small vessel disease, which I'll let the cardiovascular specialist talk about, but can't be revascularized because the vessels are just so small. Think of it like a big tree. The tree has a trunk, it's your aorta, it branches out to all the small branches. The tiny little twigs, if you will, are the small blood vessels that get out into the toes that can't be revascularized. They're, trying their hardest by reperfusion and creating different pathways after revascularization. But with that said, if that plus continued compliance is not actively addressed or focused on the totality of the patient's care, then certainly these, think of it like plumbing. These pipes can be reclogged again, and unfortunately, certain things can transpire. So they're absolutely not, to your point, and they not caused by the cardiovascular specialists at all. In fact, an active role to get them plugged in sooner than later. And even in our practices, we screen the patients. We actually perform non-invasive vascular testing to ensure that they fall into certain criteria. preventive medicine is huge now. And as long as they're actively enrolled in that type of care, it helps mitigate these unfortunate consequences that can result into some form of amputation, whether it's a toe amputation, a partial toe, or foot amputation, something like that.
Thanks, Al. So let's get to the meat though of what the New York Times was saying. So they clearly missed on giving an appropriate context, right? And they actually missed, and we spent a while talking about this on the last space. They missed on even their target. They could have picked bad operators. They chose to pick Dr. Mustafa, who is who is probably one of the most. Again, this is from talking to a number of vascular specialists. He's one of the experts in the field, highly published, and is very technically proficient. And from his reputation is very, very good. And again, the case they represented in terms of who he intervened on, I think, again, not speaking to the details without knowing all the specific details, but generally speaking, doesn't seem inappropriate. So they seem to have missed even on choosing, the bad actor. But getting to the meat of what they were saying, is there is reimbursement that changed, which means that instead, that physicians on the outpatient side can collect both the professional fee and the technical fee for a certain procedure, to revascularize arteries, and that clearly does create an incentive, right? Which is what CMS wanted to do. There's nothing bad about this. CMS wanted to create that incentive to get care to the folks who most needed it. The folks, by the way, the folks who are most suffering amputations aren't folks in high socioeconomic status zip codes in Beverly Hills. The folks that are getting amputations are frequently folks that are in the poorest of the poor zip codes in the United States, frequently Black, frequently Hispanic, and the goal was to get out to that community to prevent this. So that's why CMS changed reimbursement. That being said, when you do change reimbursement, you do create that incentive. There's clearly a lot of room for bad actors to enter. One of the things that the New York Times, so I have two questions that Vince, I'll have you take first. We'll get you on. One is most of the work that's being done in the community, do you have a feeling, and even more than a feeling, is there data to suggest that the vast majority of work being done in the community is done on, asymptomatic people or mildly symptomatic people, or is it being done in patients that are at, significant risk of limb ischemia? Is that a problem in outpatient vascular medicine at the point? And if it is a problem, like, what is the scope of the problem? Is it is it just these bad outliers that are doing these things, or is this really rampant through the field? What is your sense? And I don't know if anyone can speak to what the data may say.
I think going back to the point that you made, that part of the mission of going in the outpatient field was to provide more care to patients that weren't able to attain it in those communities, like the less served community, the Black community, Hispanic community, getting that ability to see a vascular specialist and get those legs taken care of. In addressing your question, is there an uptick in patients who are asymptomatic or may have minimal disease going for procedure? Not, as far as I know, that's not the case. It really shouldn't be the case. Like you said, there are always bad actors in every specialty, including vascular medicine, cardiology, interventional, radiology. But the vast majority of physicians that are taking care of patients in an asymptomatic patient, they're not going to be taking them for a procedure unless there's a good reason otherwise. Most of those patients can be managed medically. The patients that will go to procedure are those patients that have lifestyle-limiting claudication, patients that may have failed medical therapy or can't tolerate certain medications, or the patients that have critical limb-threatening ischemia of the lower extremity, wounds, the potential for amputation. I think one of the things that the article also failed to mention, because they really sort of drew a direct line out of context of, patient going for a procedure with a wound and getting amputation, the thing they don't talk about and what we see a lot of is when we go and see a patient with a wound on their leg, to prevent amputation, we try to revascularize the vessels and open up the arteries. Sometimes it doesn't mean there's no amputation, but it may limit the amount of amputation. So instead of having an above the knee amputation, a patient may instead just lose a few toes, or have a transmet amputation. And that means a lot to patients who can remain functional. Because once you have an above the knee amputation, we know that their 1 year mortality is 25%, largely related to their deconditioning and inability to move. And then, another quarter of those patients will have a contralateral amputation. So having an amputation is a big deal for patients, especially when it comes to mortality and it comes to their daily living. So if we can minimize the amount of tissue loss by opening up vessels and restoring blood flow, then that's what we should be doing.
Thanks. So, just make sure you mute. Yeah. so, so you get a feeling that that's not happening. Does anyone know, John? Do you know if there's data that specifically speaks to what percentage? I think Jay said something to the effect of 50% of interventions that are happening. I don't know if it's overall or in the community versus academic setting or whatnot, is happening for critical limb-threatening ischemia. Hopefully most of the rest is happening for the indications that Vincent spoke about. But how do we get a sense of how much inappropriate care is happening in the community, and do the vascular surgeons have and the vascular surgeons have suggested that we don't have good data and that we do need more data to figure this part out. Is that something that we just don't know and we need to actually sort out? Is that actually something that's actionable?
Yeah, absolutely. I mean, I think that's a really important question, and I'll tell you that there's unfortunately, the data that we can mine is biased. We have Medicare data that we can get, and then we have procedural databases that are housed within different societies, and then the most common one that we use is VQI database. But these are self-reported data sets, and so unfortunately, what we can glean from that is going to be limited. It's going to be biased, but the information we have is the information we have. And from what we can tell, a lot of the cases that are being done are for limb-threatening ischemia, and there's lifestyle limiting claudication refractory to medical therapy or conservative therapy, including supervised exercise. Having said that, like Dr. Verghese said, there's no question there are going to be subsets of operators and locations where there's going to be overuse. And there's a big push within even the outpatient world to standardize that information. So there is actually a whole society that was formed, the Outpatient Endovascular Interventional Society, OEIS, that has its own data set, and so that's being published yearly as to what what they can gather from the outpatient labs that are participating in those societies' data gathering efforts. But to put all of that into one bucket and say that outpatient interventions lead to amputations, which is what this article said, I think is far away from reality and the truth. And I'll also jump in and say that there was another big error, the other thing that they went after. So they went after outpatient care, and they also went after atherectomy. And so those are the two subsets of cases or interventions that they went after. And to just switch gears a little bit and talk about atherectomy a little bit. Atherectomy is just a technique to be able to debulk some of the plaque within the vessel to try to minimize the amount of stenting that needs to be done. And so we have, so many different techniques. You have plain balloon angioplasty with a balloon to open up the blockage. They tend to recoil and repair within a short period of time. Atherectomy allows you to debulk some of that plaque and excise some of that plaque. It may still have a restenosis rate or a recurrence rate. And then you have stenting, which is a permanent implant inside the artery, a scaffold, if you will, to try to keep that artery open. So these are all techniques and options that you have. And they specifically, in this article, went after atherectomy as a direct link to amputation. And that, again, was an error without really looking at the entire data set. They did quote two articles, They had two patients, and they quoted two articles in the entire paper. And it's unfortunate because you have a huge amount of data. Now, having said that, they're individual industry-related data, looking at specific atherectomy devices versus balloon angioplasty. But the two articles that they quoted, one was on atherectomies leading to increased amputations. And if you just even look into that data set a little closely, I pulled up that article. It's a retrospective analysis looking at Medicare data sets from the VQI database. And they looked at atherectomy as a standalone, and they excluded any patient that had atherectomy with stenting. And the goal of that article was to actually compare atherectomy versus standalone balloon angioplasty versus standalone atherectomy versus standalone stenting. And they never even mentioned stenting in the article, but that article's conclusion was that stenting is the best option for these patients. Now, if you ask any vascular specialist currently, as far as techniques to treat patients, we try at our best to try to avoid stenting, to minimize the amount of stenting, because a permanent implant has permanent implications for that patient. It requires antiplatelet therapy. It still has a restenosis rate. You can still have fractures within the stent. You can have all kinds of issues in the periphery that you don't necessarily see in the coronaries as much. But we've gone to the algorithm of trying to minimize stenting and using more drug-coated therapies to maximize the patency of the vessel after an intervention. So to really see that, they used one single, reference of atherectomy leading to increased amputation after they excluded all the patients that had mixed therapies, which is the majority of the patients that we treat, is really a biased reporting of outcomes, in my opinion. And so I think that also had huge implications.
Is that so? Why is that? Is there in terms of who published that article? Is that the vascular surgeons who?
Yes, that came from a vascular surgery subset. I forget which institution, but yeah, it came from the vascular surgery specialty. And there are varying practices between specialties that also need to be standardized at some point. I think there's a lot of comfort level with atherectomy among cardiologists, mostly because we use atherectomy in the coronary side. We have a comfort level with utilizing atherectomy in the peripheral space as well. But that doesn't necessarily mean that that's the right treatment. But to say that it leads to increased amputations, I think it's a far-fetched claim. And so I think that's what was concerning about the New York Times article as well.
It seems like it seems to be the case that does vascular surgery generally feel that atherectomy is something that does lead to more amputations? And meaning, how do we? And I mean, they seem to be generating data, but the data, of course, has some issues with it. But is this just a difference between specialties in terms of how they're taking a view of things? There's obviously some significant conflicts in part related to this, but is there a separate body of literature from the interventional community, the primarily endovascular interventional community that suggests atherectomies? Like, what is the best data like for atherectomies? Like, if you had to come back at them and the New York Times and say, hey, this is not the case, how would you go about kind of rebutting them?
Yeah, so I can give you my opinion, and maybe Dr. Verghese can jump in as well. But I'll tell you that there's no question there is a paucity of data. What we have currently on the peripheral side is individual industry-sponsored clinical trials that end up getting a product approved for the market. So atherectomy devices come in multiple flavors, created by different industry sponsors. They each have their individual data sets, which are legitimate data sets that the FDA requires before it's approved for use. And so you have actual comparisons, randomized data of atherectomy, a particular atherectomy device compared to balloon angioplasty, because balloon angioplasty for the longest time is considered standard of care. No one does plain balloon angioplasty anymore. So everything that has come to market is compared to balloon angioplasty. And so we have extensive data looking at atherectomy versus angioplasty, and that repeatedly does better. Even in the article that looked at atherectomy and was cited as the atherectomy leading to increased amputation rates, found that the amputation rates were even higher with balloon angioplasty alone. So even in their own article, balloon angioplasty itself is not the best option. And so, I think that's the only comparison we have. As to head-to-head comparisons between different atherectomy
Yeah, just just click on the go to your email. Yeah, go to your email and click on the link. Click on the new email that you got. So keep going because the Twitter Heart Spaces is still going. But when you, yeah, if you can multitask, go to the email and click on. There's a new Zoom link. That's all. It just ended.
Cassano's data set that came in, stating that there was increased mortality with DCBs and drug-coated balloon technology, which kind of put a damper on using drug-coated balloons, which was heading towards being the standard of care in the peripheral space to try to minimize stenting. And now we have drug-eluting stents. And so, we have comparisons of drug-eluting stents versus bare metal stents. We have comparisons of one atherectomy device versus balloon angioplasty. We don't have an all-comer comparison because there's so many technologies and so many different techniques available within the peripheral vascular space to compare each of them head-to-head. So there are limitations in what we can compare. But I'll tell you that in the end, we can talk about details and nuances of each kind of technique, but in the end, it's about revascularizing that patient, especially with critical limb-threatening ischemia. What we want to do is open blood flow so that wound has the best chance at healing. And like was mentioned repeatedly, it doesn't mean you win each and every case. Victory lies in how the patient presented and what their entire picture is, as well as was mentioned before. Sometimes they come in with 2 toes and 3 of them are black, and they're almost falling off. And you're not going to save those toes, but if you limit it to a toe amputation as opposed to losing the foot or a BKA or an AKA, that's victory. But it still counts as an amputation. So it's all about how you define these outcomes and how the patient did in the long run. And so if you're able to make that lifestyle for that patient better, I think it's a victory.
It's super interesting because of how things come full circle, right? Because angioplasty and opening up arteries endovascularly, not with an open surgical technique, started with daughter, right? So before any cardiologist is running around snaking catheters into coronaries and opening up arteries, the original case, the original way this was all described was in a little old lady who was deemed not a surgical candidate, right? Who was left basically to have her foot basically be rotting off or something like that. And I think Charles' daughter is his name, correct? Am I getting that right? He took a patient, opened up that artery, and had this and the foot and wound healed. So there's something about we can talk about RCT level evidence, etc. But as you're kind of getting to the point that look, we need to get blood to that area, and anything that helps that is obviously seems to be good. What about the point made about look, a lot of this is happening, and we're not even considering vascular surgery. Now, again, it's an important point to make that some of the data, especially some of the stuff coming out after the Vascular Surgery Society, involves patients that are deemed not candidates, right? I mean, these are high risk folks. But what about the idea that we are not even as peripheral folks, or certainly in the community, or even in hospitals or whatnot? What about the idea that these folks are not being appropriately considered for surgery? And are there cases where surgery is better, has better outcomes? Is there some corollary to the coronary space where bypass surgery for certain things is clearly better than stents in the coronary? So can you teach us a little bit about that? Vince, you can go, and John and Al, if you want to chime in, let me know.
Yeah, thanks. I'll speak a little bit about that. I mean, we've been working in collaboration with vascular surgeons for a long time, and any vascular surgeon really would say, if you ask them how are you going to approach this patient that may have limb-threatening ischemia or claudication, most surgeons and most interventional cardiologists would say we would pursue an endovascular first approach. Because that type of approach has minimal risk to the patient. The recovery is much quicker, no surgical wounds to heal. So most of the time they're going to approach that from an endovascular standpoint, be it with stents, balloons, atherectomy. And again, atherectomy, I think there is a little bit more of a bias as far as, I think interventional cardiologists probably use more atherectomy than, say, a vascular surgeon does. But that just is a specialty type of difference. Now, when it comes to surgery and how I use surgery for my patients, a lot of times we'll do procedures on patients, we'll open up arteries, and they close. And then we do another procedure, and we do a different technique, maybe a different atherectomy, or we stent, or a drug-eluting stent, and they still close. So if they've had repeated restenosis or repeated occlusion of an artery, then surgery makes sense. I mean, I definitely send patients to surgery in those situations. Because they've proven that endovascular techniques may not be the best thing for them. That doesn't mean the surgery's 100% foolproof either. Like, those grafts can fail also. And part of the responsibility has to go with, just changing, diabetes control, stopping smoking, being responsible for your own health. If a patient continues to make poor decisions as far as their health goes, then our work that we do is gonna close. So I consider surgery sort of a tool that we can use in patients that fail endovascular therapy. But for the most part, we try to do an endovascular revascularization approach first.
And so is that pretty well accepted? Is that pretty well accepted then, that that surgery is only for folks that are unable to get? And is that I'm just trying to get at what maybe differences that in different specialties. Is that something that is accepted by vascular surgery as well, that you should try endovascular, and then if it doesn't work, then go to revascularization?
I think that depends on where you are. That may depend on, that's an institution type of culture also. So, if vascular surgery has a heavy presence in an institution, and maybe they don't believe that endovascular first is their approach because they were trained to do open surgery, then patient's going to go for open surgery. It also goes to the question of, there's still a large amount of patients out there, like you said, that go directly to amputation, that never even have an angiogram done or any type of CAT scan or any type of mapping of their arteries to see if they can salvage the limb before going to amputation. So I think it just depends on where a patient goes for treatment, and the person taking care of them and their comfort level. So people can go to surgery first as well.
Thanks.
I'll make a comment there as well. So there's no question that the expertise varies, right? So the complexity of disease varies. The area, the vascular bed where the problem is or the culprit lesions are vary. And so it's a patient-to-patient decision. So if you look at going from the aorta all the way down to the toes, generally speaking, there's a whole classification system for the complexity of disease. And so, there's a task lesion classification from A being the simplest lesion to D being the most complex lesion. And generally speaking, if it is D, then there's benefit to going with surgery. But the caveat there is that they still need a good vein conduit to be able to do the bypass. And where you hook up that vein conduit also matters. And so this is best spoken by a vascular surgeon, but what I can tell you is that once you go to anastomosis below the knee to a tibial bypass, the patency rates drop significantly. And once you start using synthetic grafts as opposed to using autologous veins, patency drops significantly. And so all of that has to be taken into effect, whether the patient has adequate vein mapping to be able to allow autologous veins. There are simple vascular surgeries like endarterectomy at the common femoral level, which do very well. They're very simple, straightforward from a surgical standpoint. Lower risk procedures can be done very effectively if it is isolated common femoral disease. But the reality is, a majority of the patients that we talked about this being an epidemic, majority of the patients that we see are high-risk patients with a lot of vascular disease and comorbidities that have diffuse disease extending all the way down. And so your options are limited. And what we're trying to do is make a dent in preventing amputation. So if you can revascularize to the best of your ability. If it is bypass, let it be bypass. If it is endovascular, let it be endovascular. But the key is to get it revascularized. And whatever your strengths are, do it that way. But get the patient treated with blood flow. But what we're trying to do is limit the number of amputations in this country, and those numbers are staggering. And there's plenty more work that needs to be done to make a dent in that space.
Yeah, on the stream that's being published YouTube Live, there's a I'm showing from the blog that I wrote about this. I was just looking at the amputation rate. I was like, okay, endovascular procedures have massively gone up, right? And if the idea is that we're having more amputations as a result, that means that we must have like even more amputations than before. But guess what? If anything, the amputation rate has come down. What I found was up to 2012 or something like that. So I don't know if more recent data suggests something different, but certainly it looks like if you look at the graph that's on the YouTube live stream, you see endovascular interventions kind of skying up, and the amputation rate, if anything, going down, kind of suggesting that, hey, look, broadly speaking, bad outliers, if there are, they may be there, but broadly speaking, CMS's efforts to get more blood to the toes of patients that need it is working to stave off amputations. But what about the idea that the reimbursement is so different, right, in the hospital setting versus the outpatient setting? In the outpatient setting, you are being reimbursed for every single thing that's done, right? So if you choose, so what that does is that puts it puts an incentive for physicians on the outpatient side to choose devices and procedures, not necessarily because there's the best evidence to use them, but because they get reimbursed the most with them, right? And that's one of the issues with atherectomy, is that atherectomy is one of the better reimbursed, CPT codes, procedures. So how does one, is there something that you guys can think of that would, obviously the reason atherectomy is reimbursed more is, I imagine, it's there's more capital cost for it. It's more expensive. The risks may be higher, etc. But how does one? Yeah, how should one deal with this? Because obviously we have to answer to the public in terms of some of this stuff.
Yeah, I can take a stab at that. So, there's no question there is a generous reimbursement for atherectomy, and that's I must caution the statement that it pays more in the outpatient space. It pays differently in the outpatient space, but there's reimbursement in the U.S. healthcare system is very complex, and so you have facility fees, you have physician fees, and you have these CPT codes. If a patient becomes an inpatient, and then you take away all of those payments, and you get a DRG for that inpatient stay, which is massive, and that becomes significantly higher. So the fact that there are statements being made in this article about the incentive to do these procedures in the outpatient space, there's no question that the money filters down to the physician operator much more significantly in the outpatient space, because there's less overhead, there's no facility fee, and so all of the payment for the atherectomy and the CPT code is coming, directed towards the operator and the low overhead in the outpatient facility. But having said that, atherectomy has a very high reimbursement in the hospital outpatient space as well. And so to say that there is no incentive in the hospital setting to do atherectomy is also false, because there is a hospital incentive to do more of these procedures just because of how payment is set up in the U.S. healthcare system. And so, yes, there are problems that are much larger to tackle outside of this topic, with how payments are made for healthcare in the U.S. But having said that, the way reimbursement is determined, and this is reevaluated every year by CMS, and they've been steadily coming down on these payments, actually, from what it used to be for atherectomy in the outpatient space. But it's based on the cost, like you mentioned, how much time it takes for that procedure and the overall cost that goes into the care of that patient. And they have a very complex model and calculator to come up with what that is worth to make a payment for. And they come up with these numbers, and every year that number is different. And so, yes, there is an incentive, a physician operator incentive in the outpatient space for any procedure. Procedural-based specialties in the outpatient space, because it filters down to the physician operator. But that incentive is there, and it's the flaw of the U.S. healthcare payment system, that we are more procedure-based than outcome-based in our payments. And so as you do more procedures, you get paid more. And that's also true in the orthopedic space, where there's this incentive to do more procedures in elderly patients. And so this has been a dilemma that I'm not sure we're going to get an answer to in this discussion.
Yeah, no, that's a very good point. Yeah, so what I meant to say is, when you're paid by DRG, which and it's so complicated that there's a certain criteria that decides when you go to a hospital to get a procedure done. There's certain criteria that makes it an outpatient procedure, so it's a hospital-based outpatient procedure, or you get admitted as an inpatient, and then you get the hospital gets a DRG payment. That DRG payment, you're absolutely right, is pretty darn big. But the interesting thing is, when you have a DRG payment, you of course there's the incentive in the system to to do the least possible because you're getting paid a lump sum payment for this diagnosis, right? If you end up using six fancy catheters, or do IVUS and do all this stuff, you're actually chipping down, you're reducing those margins. So it's just such an interesting, yeah, it's such a complicated thing. But you're you're of course correct. We're not going to get to the bottom of how one deals with incentives. And I think one of the things that and that me and Michelle Accad talked about all the time is that's why I think we forget this. There's no system that is necessarily going to solve this, right? You're always going to have unethical physicians. So what is the goal? The goal is to make sure you're selecting for principled, ethical physicians that, despite having the ability to do X, Y, and Z, will not choose to do X, Y, and Z. And for some reason, we're just obsessed with creating these systems to try to minimize incentives to do more. And I see John Mandrola is on, and I think we've had many arguments over the last decade or so with John about the fact that yes, the United States healthcare system is incentivized to do a lot, but if you create incentives not to do more, you're certainly going to create harm in certain groups by doing less. I think John's of course very good point is that we're just net doing too much, but and therefore we should just, if we did less overall, then we would net benefit. All right, I've been remiss to not get Al's point of view here. Al, what are your thoughts on some of the things that us wacky cardiologists have been talking about so far?
Yeah, first I'll just echo what's been said. To just take it in reverse order, I think first and foremost, there's no question that the literature is replete with data that supports functional levels of amputation. And so the goal from a very basic level is to make sure that those patients have optimal vascular inflow. And we're not talking about just patients that meet all of the check boxes around smoking, uncontrolled diabetes, hypertension, cardiovascular disease. These patients that are also undergoing orthopedic type of procedures in the foot and ankle lower extremity space need to make sure that they have maximal revascularization to encourage healing, because regardless, there is still a potential that they could have a wound healing problem or incision healing problem, and so it is critical to have a tight relationship with cardiovascular specialists to help maximize flow. Secondly, we've talked a lot about how these incentives take place in the outpatient setting. Let's not forget that these incentives are driven by the insurance companies and healthcare industry as a whole, which what I'm getting at is that ultimately, when you look at orthopedic-related procedures, as Dr. George pointed out, there's no question that everyone is moving towards outpatient total knee replacement. Why? Because the patient recovers faster, they can go home the same day, they can function at home, they can be walking and less being bedbound in the hospital setting. And the cost of the overall healthcare system drops dramatically because healthcare industries, including insurance companies and Medicare and so on and so forth, want to decrease length of stay. They want to decrease patients being in the hospital. And so the buzzword across all healthcare-related fields as a whole is minimally invasive types of approaches. And that's where these types of approaches that we're discussing here in the cardiovascular space are critical. Why? Because you're not burning any bridges. You give the patient an increased opportunity if they are successful in a revascularization performed endovascularly, and then they can heal their wound, they can go on to continue having a patent blood vessel, and they can preserve their limb, including less functional demand by a more proximal level amputation. So with all that said, this article that was published in the New York Times, which is by far completely off kilter with just the landscape as it should be, should represent the fact that there's no question that those facets, and the theme of this conversation is that there is not one size fits all patients. We take everything with a grain of salt with every single patient as they present, as their comorbidities present, as their home and socioeconomics presents. And all of those are factored into the equation. And, I give a lot of credit where credit's due, because I can tell you the cardiovascular space, they're fraught with, as I mentioned earlier, small vessel disease. And, as I alluded to earlier, even in the best of hands, unfortunately, it takes a team effort, including the patient's effort in that regard, to really ensure that their patency rate remains long term. So, to everyone's point on this call, there's plenty of work to be done in the literature space and research, but there's tons of evidence to support everything that's been mentioned.
Thanks, Al. Those are all fantastic points. But we're coming to the end. I'm going to open it up to questions while we finish up for the last 5 minutes or so. So anyone with any points, please just raise your hand, and I will see it on the Twitter Space thing, and invite you on. So just kind of rounding off in terms of trying to give a bone. Right. By the way, I have the ProPublica piece I thought was much better done. The ProPublica piece really does seem to focus on cases that are mildly symptomatic or asymptomatic patients with a bad operator who happened to be a vascular surgeon. Who set up a large, beautiful, ornate vascular center, and appeared to be running a massive mill where there was a crazy case of somebody who came in with a woman with bilateral itching in her legs, and the first thing that was recommended was not a vascular study even, it was a angiogram. In second opinion, vascular study was normal, and turns out that it was a spider bite or something, and that was actually reported to the medical board, and because he had a spate of medical complaints. This is Dr. Jeffrey Dormu, who's kind of pictured on the YouTube live stream. After about 2 years of an investigation, they actually shut him down, took his license away. He's no longer practicing, and the vascular center website that he was running, that website is no longer active. So that I encourage people to read that piece as well, because I think that did make some it does do a better job at least of identifying levels of concern, as opposed to the New York Times piece, which took a poor lady who looks like she was going to lose her limb because she already had a non-healing wound there, and kind of tried to make a bad guy out of one of the world's experts in revascularization, in terms of, and saying, oh, that's why the limb was lost, which is kind of crazy. Any thoughts? I briefly broached this topic, moving away from some of the technical stuff. I briefly broached this topic with Dr. Gary last Sunday as well, about training programs and training programs being. This is a broader question about medical education. Do we do a good enough job of filtering folks before we say you're okay to practice independently, on patients? Whether it be at the internal medicine level, whether it be the fellowship level. Are we just, how many patients, how many surgeons, how many cardiologists, have you heard of that don't make it through fellowship? Are we really that amazing at choosing cardiology fellows that every single person who joins a cardiology fellowship, every single person who joins an interventional program, are we really that good that almost every single one of them ends up, with a stamp saying, hey, you can go out and practice and do your thing?
Yeah, I'll address it if that's okay. I mean, I was in charge of a training program for a good 9-10 years, and I could say that a large part of it again has to do with the training program itself. What is being taught to fellows? Most fellows come in with a pretty open mind, and are going to mirror a lot of what their mentors are doing. We all have mentors as we all trained, and people we looked up to and people we wanted to emulate. And so those figures in our life play a big role in who you want to be when you get out of training. There's always, bad seeds in any massive, collection of professionals. I think fortunately that's a very, very, very small number. But that type of behavior, if you're talking about people that are in it strictly for the money, that are people in it strictly for profit and not caring about patient care, I think that's a very small number. but I think it's something that is taught in their training program. I think it's sometimes, most fellows that leave training programs don't just go into private practice by themselves and don't just go and start their own outpatient lab. Most of them want to join a group. They want to get their feet wet. They want to join an academic program. They want some more mentorship when they get out into the real world. So I think fortunately it's a small number, but that's a reality, unfortunately, that we always kind of see, where you have a few people out there that abuse the system and sadly abuse these patients that are already going through a lot and suffering. So, it's really up to other physicians like us to see these clinicians that are practicing and be brave enough to report them maybe to the medical board, or let others know that something's wrong here and something's not being done appropriately. So it's really up to us to kind of look at that and see what's happening, because we can see a lot of what a lot of lay people can't see and understand when something's appropriate and when it's not.
Go ahead, John.
Yeah. So I agree. I'll second a lot of what Dr. Verghese mentioned. We as mentors or trainers see our fellows and residents passing through for anywhere from 3 to 6 years, and or maybe even 1 or 2 years in a subspecialty fellowship. And there's a lot you can tell about their ethics and about their technical skill during that time period. But there's a lot that you can't tell, and a lot that changes sometimes when they go out into practice. And unfortunately, that's not something that you can control. And so one of the big pieces that the societies are starting to address, and unfortunately, that is this need that Dr. Verghese brought up of mentorship. A lot of people, your entire period of training, all the way from medical school through residency and fellowship and subspecialty fellowship and some even postdoc periods, is a time where you're sheltered within a space where you have a lot of people guiding you and leading you. And then all of a sudden you're thrown into sometimes your jobs where you're solo and you're all by yourself and you're making decisions in a vacuum. And sometimes you can make mistakes in those spaces without having somebody to guide you in some of those different. And sometimes these decisions are not necessarily intentionally wrong decisions. They're just decisions that are wrong because of lack of experience or not enough guidance, and so that perhaps can be helped a little bit with mentorship. And so there are now mentorship programs set up within, at least within the interventional cardiology societies, and I'm sure within a lot of the societies where fellows are not just left alone as they graduate, but they have more continued lifelong mentorship available to them. Now, whether they utilize them or not is up to them, but at least there are opportunities available where they can use that. And the hope is that you can minimize these lapses in judgment or errors. But those are few, and they're smaller in number, as was indicated. I think majority of the time we went into this field and went through so many years of training to do the best thing for our patients, and we try to do the best that we can with the resources that are afforded to us. So just my thoughts on that.
Yeah, I don't know. I'm just not sure that we are. All that being said, I can't believe that we are that good. Meaning, it's very, very rare for somebody entering an interventional cardiology fellowship to not finish their fellowship. It's very, very rare for somebody starting a CT surgery, for entering a CT surgery fellowship, not to finish. Neurosurgery is the same way. I mean, actually, those are actually a little. Those the attrition. There is an attrition rate, right? There's a much smaller attrition rate for interventional cardiology. And when you come out as interventional cardiology, you can do a lot of different things. I worry, and I think if we don't do a better job of policing ourselves, I'm concerned that that the system that's going to come down to kind of push on us is going to be one that all of us are not going to like. I see John has come on as a speaker. John, what are your thoughts on what you heard here?
I just had two questions on the issue.
Yeah,
Can you hear me okay?
I can, yes.
Okay, my one question is, are you sure that the reason that CMS, the reason that reimbursement is so good is such a benign reason to improve access, or do you think it's just more good lobbying? That's my first question, is the causality of that really good reimbursement. And the second question is, and I may have missed it because I had like a 5-minute phone conversation, but did you all speak of the very strong industry conflicts with industry loaning doctors money and seemingly being very, very involved with this? And I understand that these are industry heavy devices, but I just wondered if those two topics were worth an answer.
Yeah, John, so John is asking a great question about the fundamental motivation to CMS. Was the change in reimbursement driven more by lobbying rather than by any altruistic intent? I think CMS always does things to try to reduce costs because they're running out of money, and so I think the main thrust was, yes, there's some obviously increasing access, but it was because things are so expensive in the outpatient setting. Even right now, an atherectomy in a hospital-based outpatient, when it's not a DRG, which is massive payment there, it's $10,000 versus about $7,000 doing an atherectomy in ASC. So it's 30% cheaper to do it in ASC. So I think that was probably a big part of CMS's underlying push to do this. And of course, if that means that there's a lot more procedures done and CMS's budget hurts, I guarantee you CMS will then make other adjustments to make their balance sheet look better. The other question is great, and one that I forgot to kind of touch on is there is a very, very close, cozy relationship, both from a training front, educational funds, etc., and of course, Philips, etc. These companies that make these devices that have certain capital costs, they will loan patients money as part of their finance arms to do this. I'll say that, look, I mean, there's when I bought an Echo machine, Philips, or was it Philips? No, yeah, so whatever company I use, not Philips, lent me some money and so that I could, finance it over 5 years. So I don't know how much to make. That's just part and parcel of operating in a world where somebody else, meaning academia, academic, etc., is not paying the bills. So I'm not so burnt about that. It's like everyone is going to have a financing arm. It's like when you buy a car, they have there's Toyota Finance, there's etc. So I don't know how much that is that bad. It just reflects the real world, which the New York Times and a lot of academics don't necessarily live in. But what about this cozy relationship that folks have in terms of setting up meetings and conferences to train you on this catheter and that catheter, and then you get people flying in that are paid for? Is there then a increased incentive to use these devices, not wait for trial data? Is that affecting the objectivity of the operators that are using these devices?
So, I mean, that's a great question, John, about this relationship or conflict of interest with physicians and industry partners. But I'll tell you that this is, like Dr. Koka said, this is close for most locations, including hospitals. I will tell you, having worked in a hospital setting for 15 years, it's what hospitals do for capital equipment as well. They have, per use payment models where you don't pay for capital equipment as long as you use a certain number of catheters per month, and you try to make that judgment based on, what your volumes are in the hospital. These loans are made on a routine basis from industry to sites of care delivery, whether that's right or wrong, routinely. And that's not isolated to the outpatient space. And so to bring it out in this particular article stating that doctors take loans to start, outpatient labs, that's not really just isolated to that space. It's everywhere. And because it's expensive, it's funny that Dr. Koka mentioned a car loan, because when I wrote a rebuttal piece to this article, that's exactly what I likened it to. I likened it to getting a loan from a dealership as opposed to getting, a loan from another source. And you're obviously going to take a loan out that serves you the best rate. And sometimes that is from the dealership, from the same vendor that's selling you the car, and sometimes it's not. And so if it makes sense to get that loan from the industry donor, that is what's done. And that's done in the outpatient space, that's what's done in the hospital space. And that is true. It is a reported conflict, but it's disclosed. Everyone discloses these, and now with open payments, it's all out there. So if you question that, you can actually search and see where a given physician or operator might have conflicts. But whether that affects the actual treatment, like I said, and like we repeatedly said, there's plenty of bad apples, and no one's saying that everyone's in it for honesty and good morals, but I think majority of the time it is not one that affects patient care. As far as doing training and courses, I will tell you that there's no question it's the operators that get facile with a particular device that are going to be the ones that are doing the courses for that device. It just makes sense that you would be the ones teaching the course because you have the most experience with that particular device. Is that an incentive to do the course? I just think it's just a natural way of progression for a lot of these courses where it's inevitably going to be taught by somebody who is an expert
Is
utilizing
it
that device and tends to be
is
a
it
conflict by nature.
is it an incentive to use a particular device more than others? Is that do you think that's something that's real?
I think it can be. I think you have to be wary of that. But I'll tell you that majority of the operators, having done a bunch of these courses, I do courses with multiple devices, and so it ends up being, a course for a particular modality that you are able to teach or train other physicians in if they're willing to learn or wanting to learn in that particular device, but or how to operate that particular device. But it's not necessarily an incentive to do more of that device necessarily, because you're teaching people a lot of different things. You especially with the training program, you end up training your students and people coming through your lab in various different technologies that are supported by various different vendors. And here we are, we're out of the Zoom again. So,
Yeah, it's okay. We're nearing the end, so it's okay.
that makes my point clear, but hopefully, you're hoping that there is no significant conflict there that changes the utilization of the device, that you're just training because you're facile and expert using the device.
I think there's 2 points to make. I give you a thumbs up on the fact that it's very. One of the things that I wish from a journalistic standpoint is that
Yeah, no, well, look, we have a question here from Mike. But we are nearing. I've used up way too much of your time. We're about an hour and 20 minutes. So, thank you so much, guys. We'll thank you so much. Sorry, we've used up a ton of your time, so I appreciate it. John, any last comments, and then I'll. Yeah.
I just was going to say that we're not going to solve the problem of intertwining conflicts in our fields, but I do think it's worth putting it out on the table.
Yeah, no question about that. No, so they're good comments. Thanks for listening, John. Any last comments from the speakers panel? Otherwise, I'm super. Thank you so much for the time. An hour and 20 minutes on a Sunday is no small ask. So appreciate it, and it's a great discussion.
Thank you. Thanks for having us. It's been a pleasure. Yep. Again, appreciate the time and the opportunity to speak about the article. Thanks.
Alrighty.
Very much appreciated. Thank you very much for having me.
Alrighty. Thanks so much, folks. We'll meet up again next weekend, perhaps, talking about something else. Thanks again. Bye.